Welcome, everybody. I'm going to give folks, as I always do, a couple minutes to trickle in, because I know everybody's really excited about the topic this evening. And we had such a good number of registrations, so I'm hoping that we have a good turnout as well. And it's such a beautiful evening, so even more gratitude to all of you for sharing a little bit of time with us indoors this evening on Zoom instead of being outside. That makes, yeah, warms my heart. We're going to be talking about hearts today, so lots of puns probably. I apologize in advance. I have a toddler, so we're full of puns at my house. All right, I think it seems like we've given everybody a couple minutes. People will probably continue to trickle in, but without wasting too much time, I think I'll launch into all of my announcements. First and foremost, good evening. Welcome, everyone. I'm Rachel Rosen Simpson. I'm the program manager at the Breast Cancer Coalition. I'm so glad you could all join us, as I was saying, to learn more about heart health after cancer, navigating cardio-oncology for breast and gynecologic cancer survivors with our special guest, Dr. Susan Dent. We're grateful to the Lisi Rosenthal Memorial Education Fund that supports coalition educational offerings like this one. Before we begin this evening's presentation, I always have a few housekeeping announcements to share. If you need closed captioning, there should be a little CC button at the bottom of your Zoom screen, and all you have to do is click on that, and you can click on what language you would like. If you missed the link in the Zoom reminder emails for accessing a PDF of Dr. Dent's slides to follow along with her presentation, I'll drop that link into the chat as soon as I'm done giving all of these announcements so you can access it there. And then I'll facilitate a question and answer session following the presentation. So please type your questions into the chat function, and I'll continue to compile those as the presentation unfolds. At the end of Dr. Dent's presentation, I'll share them with her, and we'll answer as many as we can before we try our best always to wrap up by 8:30. And just a disclaimer that Dr. Dent can't give any specific medical advice for any individual case without being your physician. So, and we have such a short time together this evening. So if you could try to keep your questions as broad and inclusive of others as possible, that would be very much appreciated. If you want to watch the presentation again, it's being recorded and it will be added to our webinar library as well as uploaded onto YouTube, and it's now publicly searchable. So I'll drop the link to our webinar library and the link to register for future webinars into the chat for you to look at as well. And then lastly, there will be a survey that pops up. It's very quick. I think 10 questions tops. And we use those to help us generate future topics for these webinars. So please give us your feedback. I do read all of them. We read all of them as a team. It matters. All right. So tonight's webinar features a very special guest and friend of the coalition, Dr. Susan Dent. Dr. Dent attended McMaster University Medical School in Hamilton, Ontario, Canada. And I went to a university very close by, so it's a region that is special to me. She completed her residency training in internal medicine and medical oncology at the Ottawa Hospital at the University of Ottawa in Ontario, Canada, a beautiful area to visit if you haven't been there. I'll keep making plugs. She subsequently completed post-grad research, a fellowship year in clinical trials at the Canadian Cancer Trials Group, CCTG, in Kingston, Ontario, and was subsequently appointed as a staff medical oncologist at the Northwestern Ontario Cancer Centre in Thunder Bay, Ontario. And in 2001, she returned to Ottawa, where she specialized in the treatment of breast cancer. In 2008, Dr. Dent worked with her cardiology colleagues, establishing a multidisciplinary cardio-oncology clinic in Ottawa, the first of its kind in Canada, which is a big deal. She's kind of a big deal, so we're really lucky to have her. In 2011, she founded the Canadian Cardiac Oncology Network, CCON, lots of acronyms, a not-for-profit organization devoted to optimization of cancer care for patients without compromising cardiovascular health. She then served as professor of medicine, associate director of breast cancer clinical research, and co-director of the Duke Cardio-Oncology program at Duke University School of Medicine. And recently, in September of 2024, she joined the Wilmot Cancer Institute and came to us in Rochester in the Division of Hematology and Oncology. And she serves now as the director of the Cardio-Oncology program, as well as the director of the Judy DiMarzo Cancer Institute Survivorship Program. We are so thrilled that she is sharing some time with us this evening and in the area that her expertise is here, and to welcome her tonight. So without further ado, take it away, Dr. Dent. Thank you so much.
Great. Thank you so much for inviting me. And I'm just going to pull up my slides here. There we go. Can you see my slides? Great. So once again, thank you very much for inviting me to speak with this group this evening. I am so honored, although I've had the opportunity to give talks to my colleagues at institutions, I don't always have the same opportunity to speak to survivors or individuals interested in this area. So tonight I'm going to talk about heart health after cancer, navigating cardio-oncology for breast and gynecological cancer survivors. I'll add a little caveat here that although my title says heart health after cancer, I would argue heart health is important throughout your diagnosis of cancer into a completion of your cancer therapy, or if you're living with cancer. So these are some of my goals this evening, are really to describe the importance of cardiovascular health in breast cancer and gynecological cancer survivors. Again, it's interesting as we look at the literature, there is quite a bit of literature emerging in breast, less so in gynecological cancer survivors, but I do have some information that I can share with you this evening. I'd also like to discuss the impact of cardiovascular risk factors, comorbidities, and cancer treatment on the cardiovascular health of breast and gynecological cancer survivors, and importantly, the real need for collaboration of cardiologists, oncologists, and allied healthcare providers to enhance cardiovascular outcomes and health cancer outcomes. So I think it's really important first to start by understanding the burden of cancer and cardiovascular disease. So these are global statistics. In 2022, there was an estimated 20 million new cases of cancer worldwide. Around the same time that year, if we look cardiovascular mortality, there was close to 20 million deaths from cardiovascular disease. So not surprisingly, cancer and cardiovascular disease are the #1 and 2 causes of morbidity and mortality worldwide. Interestingly and importantly, it's estimated that over 370,000 cancer survivors die from cardiovascular complications of their treatment each year globally. If we look specifically at the United States, the good news is that we're certainly seeing an increased number of cancer survivors. Here on the left, you see this figure, which looks at the time from diagnosis. So at the bottom here, less than a year up to the brown curves, which is those who are out more than or equal to 25 years. But the good news is that by 2040, it's estimated there'll be 26 million or more cancer survivors in the United States alone. The other very interesting statistics is that while not all individuals can be cured of their cancer, certainly people are living longer with cancer. And so now we see here in 2018 that there were over 640,000 people living with metastatic cancer in the US. And of those, there was not an insignificant number that were living with metastatic breast cancer. So when we think about survivorship, it's important to remember it's not just those people who have been diagnosed and completed their cancer treatment. Cancer survivorship really begins at the time of your cancer diagnosis, and survivorship includes not only those being treated with curative intent, but it also includes people living with metastatic disease. In terms of gynecological cancers, just some statistics globally. These cancers, which are a compilation of cervical, ovarian, uterine, vaginal, vulvar cancers, account for about 1.5 million new cases globally. But unfortunately, because of ways some of these cancers present, a disproportionate number of cancer deaths, so 680,000 in 2022. The highest incidence in mortality tends to be in East Africa, and that is due to higher infection rates with HIV and HPV, or human papillomavirus, which we know is often linked to cervical cancer. The number of new cases and mortality is expected to increase, unfortunately, in these areas, more so in the higher endemic areas such as East Africa. In the United States in 2022, there were about 95,000 new cases of gynecological cancers, and again, 25,000 deaths, so a higher rate of deaths than we would hope to see. And of the 5 gynecological cancers, you can see about 250,000 and 109,000 women are living with cervical and ovarian cancer in the United States at the current time. The story is a little bit different. Of course, with breast cancer, we see a higher number of cases, but overall, the 5-year relative survival is quite high, 91.7%. And this is really encouraging and really reflective of the earlier detection strategies and treatment of earlier stages of breast cancer. In 2022, there was an estimated 2.3 million women diagnosed with breast cancer. I should say there are a few men in there as well, worldwide, and 685,000 deaths. But when we think about breast cancer or gynecological cancers and mortality, it's also important to understand that it is not just the cancer that women are at risk of. So here's just to give you an idea, this is referring now to breast cancer, of the scope of the problem when we think about other conditions, comorbidities that women face. So here you can see in this diagram that while 3.3 women are impacted with breast cancer, cardiovascular disease impacts about 48 million women in the United States. And this is broken down into different colors, reflective of different ethnic groups such as non-Hispanic whites, non-Hispanic Blacks, and Hispanics. If we look, interestingly, at older postmenopausal women diagnosed with breast cancer 7 years after their diagnosis, the mortality risk due to cardiovascular disease is higher in breast cancer survivors than women without a history of breast cancer. And in this very interesting study that was published in 2023, what they did is they looked at the SEER database. So this is in the United States. They looked at just over 4.8 million individuals who had been diagnosed with cancer and were 10 years out from their diagnosis. And they wondered what was the cause of death? Was it cancer or cardiovascular disease? And what they observed for the entire population of individuals with multiple types of cancer, that about 13 to 14 years at that point frame, the time you're out from your diagnosis, cardiovascular disease overcame cancer as the primary cause of death. If we look specifically at breast cancer, you can see here that the curves cross about the 7 to 18 year mark, so a little bit further out. And that's when cardiovascular deaths overcome cancer deaths. And if you look at gynecological malignancies, these curves are a little bit further to the left, indicating that cardiovascular disease is a higher risk than cancer death at about the 10 to 11 year mark. So just important to realize that, well, as oncologists, we're always concerned, of course, about cancer recurrence and that recurrence leading to increased risk of mortality. But there are other what we'll call competing causes of mortality, including cardiovascular disease. So what about cardiovascular toxicity in cancer survivors? Who really is at risk? Well, I think it's important as we think about survivorship and what happens in later years, that cardiovascular risk is really a continuous risk that occurs across the whole spectrum of cancer care. So individuals who present with a cancer diagnosis have pre-existing cardiovascular risk factors and or cardiovascular disease that places them at higher risk. We then expose individuals to cancer therapy, which may include traditional cytotoxic chemotherapy. We now have immunotherapy, stem cell transplants, CAR T cell, drugs, radiation. All of these things can increase the risk while individuals are on that treatment. But then after cancer treatment, and we know for many years after, some of these treatments can have long-term side effects and long-term risk of cardiovascular toxicity and late cardiovascular complications. And this is particularly important for those people who are living with advanced disease. These individuals will have multiple lines of therapy and are at continuous risk. So this is just a way of thinking about cardiovascular risk in cancer survivors. So as oncologists, we traditionally try and come up with the best cancer therapy treatment to cure individuals of their disease or give them the longest life possible. And yes, some of these cancer therapies are associated with risk of cardiotoxicity. By that, I mean things like maybe heart failure or high blood pressure, or what we call arrhythmias, such as atrial fibrillation. But what we can't forget about is that when individuals come with their diagnosis of cancer, they come with underlying genetics, lifestyle behaviors. Maybe they're smokers, or they're inactive, they may be overweight. And what is their environment? And importantly, social determinants of health, which I'll talk about in a minute. All of these things, when you combine them with the cancer therapy that's being delivered, can increase the risk of cardiovascular disease, insulin resistance leading to diabetes, elevated blood pressure leading to hypertension, and dyslipidemia, or high cholesterol, which can therefore lead to increased cardiovascular morbidity and mortality. So I like to think of a, rather than a disease-centric approach, that we need to move more towards a person-centric model where we consider not only the cancer and the cancer therapies that we're offering, but what is the impact of all of these factors on overall cardiovascular health? So this is a study, and I will just really give you the nuts and bolts of what the study showed, published by Connor and colleagues in Cancer in 2021. What they did is they took individuals with a breast cancer diagnosis who had coexisting, they may have had underlying cardiovascular risk factors, but they specifically looked at those who developed hypertension or diabetes or cardiovascular disease after their breast cancer diagnosis. Just over 33,000 women with breast cancer from the Missouri Cancer Registry over about a 10-year period, and they followed them. Median follow-up was about 5 years. And what they noted is that if you developed cardiovascular disease, or diabetes or hypertension after your breast cancer diagnosis, you were twice as likely, which is what hazard ratio means, twice as likely to have at risk or increased risk of a cardiovascular mortality. So clearly, developing these what I'll call cardiovascular risk factors after your breast cancer diagnosis is associated with a higher risk of cardiovascular mortality. So then the question becomes, well, if comorbidities are important in terms of your cardiovascular health and mortality, are we doing a good job at management of comorbidities in cancer survivors? And unfortunately, the answer is no. Here's just a few statistics. These are from papers that were published a few years ago, but women with breast cancer prescribed a statin, so this would be for women with high cholesterol, their adherence decreased from 67%, which was prior to their diagnosis, to 35% 2 years after their breast cancer diagnosis. Also, similar trends have been seen in women with antihypertensive medication for their blood pressure and diabetes medication. And in an Ontario, Canada study, cancer survivors with diabetes were less likely to receive cardiovascular risk-reducing therapies compared to people with diabetes and without cancer. So I think, again, this really speaks to the fact that we are focused quite often so much on the cancer and the treatment of the cancer that some of these other factors are not given the attention that they deserve, and therefore adherence or even prescription of drugs to treat these comorbidities may not take place. So here's some more modern data, because you say that data was slightly old, but this is only published 2 years ago. And again, this was looking at a risk factor, cardiovascular risk factor, or a behavioral risk factor surveillance system study over a period of about 10 years. They looked at just close to 580,000 individuals who had a history of cardiovascular disease and then reported a cancer diagnosis. And what they discovered is that for those people with cancer, with cardiovascular disease, these individuals were less likely to be prescribed or take blood pressure lowering medications or medications for their cholesterol or aspirin, if appropriate, and even for non-pharmacological measures such as smoking cessation, increasing exercise, and cardiovascular rehab. All of these were less likely to occur in those patients with cancer and cardiovascular disease versus those with who did not have cancer. So clearly indicating that we are not doing a particularly good job at looking after these other aspects of individuals' health. And finally, I think that we also are recognizing in the last few years the importance of social determinants of health and the impact of that on cardiovascular disease and many other aspects of health. But this was a particularly interesting study published last year looking at the impact of social determinants of health on cardiovascular health in cancer survivors. So social determinants of health, it's a 38-item scoring system, and it encompasses socioeconomic, environment, and psychosocial factors that influence health. So you can see in this illustration that could be economic stability, education, food insecurity, community and social support, as well as physical environment and social cohesion. In this study, which looked at the US National Health Interview Survey over about a 4-year period, they looked at just over 8,200 cancer survivors, of which about 18% had breast cancer survivors. And what they really determined is that an unfavorable social determinant of health profile was independently associated with the worst cardiovascular health outcomes among cancer survivors. Strongest association in women and young cancer survivors. So now we're understanding it's not just the comorbidities and whether you are overweight or have diabetes, but also your environment and that economic stability and food security that also can have an impact on your outcomes. And when we think about cancer treatment and the impact on overall health and cardiovascular health, the other emerging area that's become very important to consider is frailty. So, we often say that it's not just your age, but what is your overall condition? So there is a frailty index that's been validated that looks at 36 different items, including disease states, certain lab values, markers of disability. These have been proposed and validated in terms of a frailty index. So what this study did that was just published earlier this year was looked at a One Florida database of all women with early stage breast cancer receiving adjuvant systemic therapy. So they were being treated with curative intent. There were just over 2,000 patients over a 10-year period that they included. And they looked at cardiovascular events, which included heart failure or include an arrhythmia such as atrial fibrillation or flutter, cardiomyopathy, so a heart that's not working very well, or as I mentioned, arrhythmias. And they looked at the 2-year cumulative incident rate of this composite of cardiovascular events. And what they found, and what you can clearly see here in this graph, is that those who were robust were in green, had the lowest cumulative incidence of cardiovascular events. But if you looked at what they called pre-frail and frail patients up here, much, much higher risk of experiencing a cardiovascular event. So this went from 24% to 42%. So clearly also illustrating that not only we have many factors to consider when we're thinking about cancer treatment and its impact on cardiovascular health. So what about cancer treatment itself and cardiovascular health? I've told or discussed some of the things that contribute to cardiovascular health in cancer survivors outside of the cancer treatment, but we do know the cancer treatments themselves impact cardiovascular health. So this is a very busy diagram, but just wanted to emphasize that not only are there many classes of drugs out there that can impact cardiovascular health, but there are many types of cardiovascular toxicity. So traditionally, many of us have heard of the class of anthracyclines, we call it the red devil, used in breast cancer and other types of cancer. Is associated with a higher risk of heart failure if you have a high lifetime dose, as I've highlighted here. And for breast cancer, we've also know about and other HER2 positive cancers, HER2 targeted agents such as Herceptin, Perjeta, and some of the antibodies now are also associated with decreases in ejection fraction or heart failure. But look at, I just wanted to highlight all the other types of cardiovascular toxicities that can occur with different types of therapy. So we've got conduction abnormalities. So I did mention a little bit about arrhythmias, valvular heart disease, particularly with radiation, which if the heart is in the field, is going to occur years later. Myocardial ischemia. So this may occur in the form of like angina, or you just get that chest pain, or can impact the coronary arteries. Pericardial disease. So this is the sac that around the heart, and this, if you have radiation, can get develop scar tissue, and you can get like what's called a pericarditis, or an inflammation of the heart. And we know that some of the therapies that we give for cancer treatment can cause hypertension, high blood pressure, vasospasm. So the coronary arteries actually go into spasm, which can cause chest pain, increased risk of blood clots, not only in the legs, but in the lungs, which can be serious, as well as stenosis of some of the coronary arteries, and you'll see their endocrine therapy. And I saw a question pop up earlier already, and we'll address more of that later, and vasculitis. So the immune checkpoint inhibitors or immunotherapy has become a very hot topic in cancer, including for women with triple negative breast cancer, and that can also lead to some unique toxicities, which I'll mention in the upcoming slides. So just to really highlight how complex this is, but importantly, how many drug classes can influence the risk of cardiovascular toxicity and the number of cardiovascular toxicities we can see. So this is where my represents about 30 to 40 years in evolution of breast cancer therapy. We talked a little bit about the anthracyclines. That's that red devil people often call, which has made phenomenal inroads and improved cancer outcomes. We have started to move away from this class of drugs as other drugs emerge, but they are still used in certainly in part of the treatment regimen for triple negative breast cancer and higher risk cancers. But it can, particularly if you have a high dose of this over a lifetime, increase your risk of heart failure. And that heart failure may occur in the immediate sense, a little less commonly, but more commonly it occurs down the road. So it can be a year or more years out from your actual cancer therapy. HER2 targeted drugs, also very important in the treatment of breast cancer. So I mentioned trastuzumab or Herceptin, there, which was, when it came out, we were concerned about the risk of heart failure. This drug can cause decreases in the heart function, but fortunately, if attended to, it tends to be reversible. That's very different from the anthracyclines, where you can get permanent heart failure if it's not attended to early. Capecitabine, the other name people may know this by, or Xeloda, is used in a number of cancers. It can cause coronary vasospasm. So it actually, the coronary arteries go into spasm, and people often feel like they're having a heart attack or an MI. So this is a problem with this drug that we can, and it can be very hard to re-challenge individuals if they experience this side effect. CDK4/6 inhibitors, so a big word, but this class of drugs is now used in combination with endocrine therapy in the first line setting for metastatic or advanced breast cancer that's estrogen receptor sensitive. And so the problem with this class of drugs, in particular, this one, there are 3 members of the family, but this one called ribociclib can cause prolongation of this, what's called the QT, and if that QT interval, which is recorded on your ECG, becomes too long, it can lead to an arrhythmia, and eventually that can actually stop the heart. So we've learned a lot about this drug, and when we prescribe it, we have to do ECGs at the very beginning. The reason why this is also important is because these drugs, or this class of drugs, are now being used for high-risk early stage breast cancer, including not only ribociclib, but the other approved drug is abemaciclib. These drugs up here are for individuals with advanced cancer who have a mutation called a PI3 kinase mutation. And again, oral made a great headway in terms of improving outcomes, but can lead to what's called metabolic syndrome, in particular high blood sugars. So this is very challenging if individuals already are pre-diabetic or have diabetes and we put them on these drugs. Often it's a challenge to try and manage their blood sugars and keep them on the same drug at the same time. HER2 antibody drug conjugates, this is what is really driven a lot of treatment options for individuals, not only with HER2 positive disease, but now HER2 low disease. An antibody drug conjugate is essentially what they've done is take the HER2 antibody and they link it to a cytotoxic drug. And then when it's delivered to the tumor, the linker cleaves off the cytotoxic agent and that goes directly to the tumor. So a really unique kind of class of drugs, but can also cause heart failure and LV dysfunction. And then I just want to briefly mention checkpoint inhibitors or immunotherapy. Pembrolizumab, known by some of you as Keytruda, is used in advanced triple negative breast cancer and also in very high risk early stage triple negative breast cancer. But this is rare, but it can cause myocarditis or an inflammation of the heart. And if that happens, it has a fairly high fatality rate, anywhere from 30 to 50%. So a rare side effect, but it's quite fatal. Now, I said there hasn't been a lot written about gynecological cancers, and that is true. However, this is a publication we put together, published in this journal called JACC Cardio-Oncology in 2023. So for those of you who are interested in specifically gynecological cancers, I think this is really a fantastic article. And this central illustration really points to not only the different types of gynecological cancers, but the different therapies that are used to treat these cancers and the respective cardiovascular toxicities. So depending on the type of treatment, these can lead to ischemia, arrhythmias, again, heart failure, hypertension, high blood pressure, or increased risk of blood clots. And so you can see here, just sort of what we've put here in the different dots is how they're used in terms of first, second, or third line. But some of these drugs also can be associated with more than one cardiovascular toxicity. And I think it's also important to think about radiation. So it's also can cause cardiovascular toxicity. Of course, radiation is a targeted therapy, and so it depends on where you have the radiation. So we typically think of this area in the chest for individuals with breast cancer, and of course, other cancers such as lung cancers or maybe lymphoma or sarcoma. We know that the detrimental impact of radiation tends to occur down the road. So it tends to be more of a long-term toxicity. So what can happen is whatever is in the radiation field, you can get inflammation that can lead to scar tissue formation. And down the road, what we call atherosclerosis or scarring of the coronary vessels. So you can get coronary artery disease. You can have a scarring of the valves. So people present years down the road with valvular heart disease. So things like aortic stenosis or mitral valve stenosis and heart failure. So it can affect the pericardial sac. So it's important when you think about radiation and the heart is in the field, how much radiation is that heart getting? So this certainly would impact potentially individuals getting left-sided breast cancer radiation. However, I will say that with modern breast cancer techniques and with techniques they're using, for instance, called breath holding, where they try and get individuals to take a deep breath to move the heart out of the radiation field. We're seeing this being less of a problem. For individuals with gynecological cancers, they may be exposed to pelvic radiation. And you would think, how does that impact my cardiovascular health? Well, again, there are vessels in this area of the body. So if you're getting radiation down here, this can impact your aorta, and it could also impact your iliac arteries, which years down the road can become sclerosed from the scarring. And that can lead to things such as renal hypertension. So that this can be very hard on the kidneys. So depending again on where you have the radiation, but I just want to mention this particularly for people who might be wondering, can this occur if it's radiation is given outside of the heart area? So I think it's the recognition of the impact of cancer therapies on cardiovascular health and the impact of pre-existing comorbidities or cardiovascular risk factors that really led to the birth of cardio-oncology. As oncologists, we want to provide the best cancer care possible, but of course, oncology or cardiologists want to optimize cardiovascular health. So it's really working together to try and do that. So a very simplistic definition of cardio-oncology is a clinically based discipline focused on the cardiovascular health of cancer patients and cancer survivors. Now, it's important to recognize that since I would say the birth of cardio-oncology has gradually increased, or the awareness of it has increased over the years, but it's probably been now around for 15 to 20 years. And during that time frame, we've seen the endorsement and development of cardio-oncology partnerships by both cardiology societies and oncology societies. So here are a number of the different societies worldwide that currently endorse this partnership. One of those partnerships is the International Cardio-Oncology Society. So I was been very fortunate to be part of the society since its inception in 2009, and it became an organized not-for-profit organization in 2011. The mission of this society is to advance the cardiovascular care of patients with cancer and survivors by promoting collaboration among researchers, educators, and clinicians around the world. And our vision is to eliminate cardiovascular disease as a barrier to effective cancer therapy in all of our patients being treated or who have previously been treated for cancer. So this organization is truly global now. We have over 1,500 members from 30 different countries worldwide. And we come together every year for our Global Cardio-Oncology Summit to try and share with each other the growing expertise and better ways of how we can approach improving cardiovascular care for cancer survivors. This, over the years, there have been a number of what I'll call position statements, expert opinions, guidelines that have been written by different organizations. This is the one that is probably the most comprehensive and the most recent. So the European Society of Cardiology, in collaboration with a number of other organizations worldwide, including the International Cardio-Oncology Society, came together. This was during COVID. It was 2 years of webinar meetings and lots of work, put together this guideline, which is 131 pages long. And it is free and downloadable online and exists in a pocket guideline, as well as the slide set and essential messages. What this guideline really attempted to do was look at all the best available evidence at that time in 2022 and try and give guidance about how do we manage cardiovascular health throughout the care, cancer care, right from the time of diagnosis through to long-term survivorship. And one of the most important things that they emphasized was this idea of a baseline cardiovascular toxicity risk assessment. So the feeling is that if we know what cancer therapy you're going to get, we also need to consider, as I mentioned to you earlier, about underlying cardiovascular risk factors and underlying or cardiovascular disease if you have that. And based on some of those components, personal history, plus the cancer therapy that you're going to be given, the guideline really talks about dividing people, or at least assigning you into a low, moderate, or a high or very high risk category, which then can determine how closely you need to be followed. So here's a diagram and really sort of emphasizes that. So here are some of the cardiovascular risk, cardiotoxicity risk factors. So lifestyle, age, sometimes females more at risk. Cardiovascular risk factors, like I said, hypertension, diabetes. Have you had previous cardiovascular disease? Have you previously been treated with cancer therapy? And then if you've had any tests, are they abnormal? So what the risk idea of determining risk at baseline takes into consideration is your heart health before cancer treatment and your heart risk from the cancer treatment. They then came up with these risk categories, as I alluded to determine your overall cardiotoxicity risk. So why this is important is because, again, when we come back here, based on those risk categories, the recommendations are you can either have standard surveillance, whatever's recommended for that drug, or should you be referred to a cardiologist or cardio-oncologist early to try and prevent you from developing cardiovascular disease. Or, if you're at high or very high risk, are there things that we can do so that your treatment can be safely given without causing further cardiovascular damage? The guideline also talks about the first year after cancer treatment, how should you be assessed? And long-term, what kind of cardiovascular tests might be appropriate for you based on your risk? Of course, overarching all these recommendations are management of any risk factors that you have in cardiovascular disease, according to existing guidelines, and informing, advising, and supporting patients to promote healthy lifestyle. So, of course, part of this or important part of treatment is engagement of individuals themselves. So the guideline has this, what patients need to know, cardio-oncology pamphlet. It is available online at this website and it's downloadable for free. And it really sort of puts into very practical points of what I should know, what can I do, what should I be asking my healthcare provider. It addresses, again, sort of, where, depending on where you are in your cancer journey, whether you're at the beginning or long-term follow-up, what are some of the things I need to think about or know about, and what can I do? So just to give you an idea for, fortunately, many people will get through their cancer treatment without any cardiovascular issues. But again, what happens long-term down the road years later? Well, it's recommended that for all individuals who's been particularly exposed to potentially cardiotoxic therapy, that they have an annual cardiovascular risk assessment, that if you develop new symptoms, you should be referred to a cardiologist. And for those who are at moderate to high risk, probably should be reevaluated. Those who were determined to be at high, very high risk at the beginning should be reevaluated for their risk at 5 years, and probably every 5 years. Now, what exact tests and cardiovascular tests you should have done? You see these boxes are all in sort of orange and yellow. The reason being is that these are recommendations based mainly on expert opinion, and we do not have a lot of high quality evidence to put these boxes in green. There is ongoing research looking at best monitoring technique, cardiovascular monitoring techniques for cancer survivors. Where the data is strongest, to be honest with you, is in childhood, adult survivors of childhood cancers. So what does that look like, sort of in a very picture-like format? A long-term surveillance in asymptomatic cancer survivors, annual cardiac risk assessment, cardiac risk stratification using that tool I showed you at 5 years, referral if you develop new symptoms, and of course, ongoing education. So when we think about a different approach to cancer care, and now this just happens to be breast cancer, but I could also say it's for gynecological cancer or really any cancer, but this just happens to be a paper that we published last year in the European Heart Journal. This sort of looks at what does that multidisciplinary approach look like? So as the oncologist will come in and speak to you about your cancer diagnosis, the stage, the prognosis, what type of cancer therapy that is recommended, there should be some sort of assessment, baseline assessment of your cardiovascular risk. Of course, then you would have a personalized breast cancer treatment by your oncologist. But here, throughout here, it's also important to work with your cardiologist to say, well, are there any high-risk features that we need to take care of before the starting the treatment? What if you develop an issue during your treatment? How do we manage that? And then into survivorship. How do we manage that for people who've had cardiovascular issues and or how do we prevent cardiovascular toxicity from coming or developing in these individuals? So this requires, awareness. It requires knowledge of surveillance strategies, survivorship programs, and clearly a multidisciplinary approach. So how do we prove cardiovascular care in cancer survivors? We need a multidisciplinary team. So it's not just the oncologist or the cardiologist. Pharmacists are important in this team. Pharmacist has a very vast knowledge on potential drug-drug interactions, for instance, that can increase your risk of cardiovascular toxicity. Primary care providers need to be informed of the knowledge or awareness of cardiovascular risk factors and long-term management. And of course, the cardio oncologist. And I put in here, nursing is also important as they often are dealing with individuals on a day-to-day basis, and exercise physiologists. And we're going to talk about exercise a bit more in just a second. Management of comorbidities, including treatment and adherence. I can't emphasize this enough. So if you are an individual and we treat your breast cancer or ovarian cancer and we cure you of your cancer, the last thing I want to hear is someone's died of a stroke because they had hypertension, high blood pressure that wasn't properly managed. So again, it's the whole individual. So we want to manage these comorbidities so that these things don't happen. Addressing disparities in healthcare is a big issue. It's something that we are just learning about. I think this is becoming increasingly important that we understand the impact on overall health. Lifestyle choices, smoking cessation, healthy diets, exercise, weight, appropriate weight. All of these will impact morbidity and mortality. And then, there have been a number of papers written on the benefit of exercise. There is what's known as the Cardio-Oncology Rehabilitation or CORE program. One of the struggles up to now has been the fact that insurers don't often cover exercise for cancer survivors. Yes, for cardiac, cardiac survivors, but not cancer survivors. And so we'll come back. I'll show you a study that's recently published in a minute that might change some of their minds. So what can you do as an individual? Well, I think obviously advocate for yourself. Discuss the risk of cardiotoxicity based on the cancer treatment and your health with your provider. Report any new symptoms to your medical care team. And I've put here on the right what some of those symptoms, typical symptoms are when we think of heart disease. So chest pain, shortness of breath, leg swelling, a faster racing heartbeat. Some people call that palpitations, increased tiredness more than usual. And this is really hard because people can be very fatigued from their cancer treatment. But any significant change, and if you're just feeling faint or dizzy, these are all things I think you should report to your cancer team, who then can interpret this based on the treatment that you've had. Monitor, as I said, for any signs of heart problems, discuss healthy lifestyle choices. And if you are on heart medication, remember to take it as prescribed. How can you reduce the risk of late cardiovascular effects? I put over here in this box on the right side. These are what we call modifiable risk factors. So smoking, stop smoking, increase your exercise activity, be within a healthy range for your body mass index, and treatment of diabetes, hypertension, and of course, hyperlipidemia. So that really is stated out here. Make healthy lifestyle choices, work with your medical team to manage your cardiovascular risk factors, monitor your blood pressure, and take your medication as prescribed. So this is really exciting. This is hot off the press. This is a paper that was presented at our annual American Society of Clinical Oncology meeting back in June and published the same day in the New England Journal of Medicine. And the reason why this is so exciting is we've talked for years about the potential benefit of exercise, potentially specifically in patients with cancer, but there hasn't been a lot of good data to say that meant a meaningful difference in terms of outcomes. So this was a phase 3 randomized study of what we call a structured exercise program that for 3 years. So people exercised for 3 years on this program. Patients were randomized to the exercise or health education materials. There was about 889 patients with stage 2 or 3 colorectal cancer who had completed all their cancer therapy. The accrual was mainly in Canada and Australia, and this study took 15 years to complete. So just really emphasizes how hard it is to do some of these studies. Importantly, if you look at these curves at the bottom here, this is what's called the disease-free survival, meaning alive and free of disease recurrence at 5 years. Look at the difference between the group who were in the exercise versus those who held health education. Now, some of you may say that's not much of a difference, it's like 6% or so. This difference is as good or better than some of the drug trials that lead to approval of new cancer therapies. So this is an amazing study. And now we can actually say to people, exercise makes a difference. So what is the future of cardio-oncology? I just have a few slides left. I just wanted to highlight that artificial intelligence is increasingly touching our lives, including cardio-oncology. So in the last 2 years, there have been many articles published on the ability of artificial intelligence to help us do things such as predict who's at risk of cardiovascular toxicity and how we can manage it. And here's just an example of what are potential applications of artificial intelligence in cardio-oncology. It probably has the most benefit in being able to pull together what we call big data and addressing some questions, such as I mentioned, how do we predict who will develop cardiovascular toxicity? How do we determine who needs closer surveillance? And importantly, what type of surveillance should we be doing for those individuals? So finally, I want to end by saying we are fortunate here in Rochester and the region to have a cardio-oncology clinic, and this is our current team. These are the indications, broadly speaking, for referral to our cardio-oncology program. So individuals who are at high risk for developing cardiovascular problems due to cancer treatment before they begin, so that high-risk group. Individuals who develop cardiovascular problems during cancer treatment, or cancer survivors who have concerns about their heart health or develop problems after cancer treatment. So, for instance, someone who may be even 4 or 5 years out from their cancer treatment, for instance, if they had breast cancer, but still have heart failure, and that needs to be managed. So those are sort of the broad categories. Your provider can refer you through the University of Rochester Cardiology ambulatory care referral, or people can self-referral, particularly survivors, and I put my email address in there. And certainly, if this is something you would consider, then I'm happy to help individuals with that. So my take-home messages are modern breast cancer and gynecological cancer treatments have led to improvements in survivorship, but clearly can impact cardiovascular health. And the risk of cardiovascular toxicity in cancer survivors is dependent on both individual factors, such as comorbidities, pre-existing cardiovascular disease, and treatment-related factors. And survivorship care really requires a multidisciplinary team to enhance cardiovascular health and ideally cancer incomes. So with that, I'm going to conclude by mentioning a few stories. So I was very privileged to meet Krina, who was a young woman diagnosed with HER2-positive breast cancer in the United Kingdom, and traveled to Vancouver to celebrate the end of her cancer treatment, only to end up at the Vancouver General Hospital in heart failure, and almost died actually because her heart function was operating at 10%. She was fortunate to meet a cardio-oncologist and improved. And several years later, she shared her story with us here at our annual American Society of Clinical Oncology meeting. And then finally, we have introduced this new Heart to Heart podcast series. And this is Julia. Some of you may know Julia. She's a breast cancer survivor living with metastatic disease, 12 years now, and also develops heart problems during her cancer treatment, but through collaborative efforts with her team, her heart function improved, and she continues to receive ongoing treatment and is doing really well. And not only that, has formed GRASP Cancer, which is an advocacy group looking at the promotion of research in breast cancer treatments. So with that, I will end and stop sharing and be more than happy to answer any questions.
That was so fascinating. I had to suppress the impulse to add questions because I was just, yeah, intrigued as have, yeah, there's some really great questions that have come in from our audience during the presentation. So I think so far we've got about 10 questions. And it seems like already people are giving you lots of gratitude. But in no particular order, I think I sort of tried to triage and put like questions together. But
Yeah.
the first question was, is it true that after 4 years, as anastrozole, so an aromatase inhibitor, creates cardiovascular issues in senior women?
Okay, so good question. So I didn't talk a lot about endocrine therapy. So anastrozole or Arimidex is a class of drugs called aromatase inhibitors, and they work by blocking the enzyme aromatase, and it prevents postmenopausal women from converting hormone precursors into estrogen. So I say when you're on this drug, we're making you super postmenopausal, right? We're taking those estrogen levels and we're going from postmenopausal to even lower. So as low as we could get them. And the whole idea behind that is to lower your estrogen and deprive any estrogen positive breast cancer cells from growing. So it's true that these class of drugs, aromatase inhibitors, have been associated, they're saying, with a higher risk of cardiovascular disease. However, I think that risk is based on the fact, not so much on the drug directly, but the fact that we're lowering your estrogen levels. So we're making those estrogen levels really low. So if you think about it, in women, premenopausal women are at lower risk of heart disease than they go through menopause. Their estrogen levels drop. Estrogen is cardioprotective, right? We know that. So I think yes, it's true. But it's more related to being, that low level. Having said that, so yes, I think time and time again, we've shown that in general, these drugs are the protective effect in terms of reduction in your risk of breast cancer is, is much higher than the potential risk of you developing significant cardiovascular disease from that drug. So it is a discussion. It's a one-on-one discussion with your oncologist, but there are millions of women out there on aromatase inhibitors, and I have many in my practice. And certainly it's something that we discuss and we manage, but it's certainly, I have not, unless, people have significant cardiovascular disease, and they have low risk breast cancer, I might step back. But I don't think overall it's an issue that's significant enough to prevent someone from being offered that medication.
And it also sounds like, in general, the takeaway message was to consider all of those other factors in conjunction with what is the medication being prescribed and what are the
Correct.
risks associated with that, as well as your, environmental factors and your comorbidities, and a holistic approach is a wonderful thing. How can someone advocate to find a cardiologist that is familiar with cancer, especially if one's oncologist seems unconcerned with cardiovascular health and monitoring long term?
Yeah, actually, that's a really tough question. So, I will come back to, our organization, actually, the International Cardio-Oncology Society, which is the ic-os.org. And what we have done in that society is we've actually shown, or we've got a site, part of that site that is patient friendly, and will show you where there are cardio-oncologists. Okay, so we have a registry. And again, this is global. So anyone who has a cardio-oncology clinic anywhere in the world who's or affiliated with our organization can put their contact information on that site. And certainly, your cardiologist, if you have access, your primary care provider may be able to advocate on your behalf, who may be able to refer you to a cardiologist who knows someone in your region. I think one of the challenges that I see moving forward is how do we bring cardio-oncology, more access of cardio-oncology to individuals? And so one of the things that we're looking at, and I think we learned from COVID, was, telehealth, telemedicine. We need to do a better job, at least for individuals to gain access. And it may not always require someone to come in to see someone or to travel 100 miles or more. Maybe that, we are trying to sort of set up that there's a virtual option for cardio-oncology consults. So stay tuned. But in the meantime, always happy to help. My email I just showed you is available. And that website I mentioned, our ICOS website, has existing practices that are currently open in the States, of course, but worldwide.
Well, that actually brings up another question, but a little bit related to the first question. So it sounds like you mentioned there are 1,500, over 1,500 individuals who are part of the society currently. Are there, in your estimation, more oncologists who maybe have some expertise with oncology, but don't necessarily yet have an affiliation with the society, such that,
Absolutely.
okay, great.
So here I can tell you, because I know the breakdown, of those 1,500 members or so, about, 85% are cardiologists, and about 10% are oncologists, and about 5% are like nursing. We have exercise physiologists. We have researchers joining the organization now too. What I have been trying to do as an oncologist is advocate for more oncology involvement. I think oncologists are also a very important part of the equation and important member of the team. And so we would definitely welcome more oncologists to become involved in the organization. There are, other organizations that have cardio oncology streams, such as the American Heart Association and the American College of Cardiology. But where I think we need to focus more on are some of the cancer meetings, such as ASCO and the San Antonio Breast Cancer Symposium and so on. And so we are trying to bring that more into the oncology stream. So I didn't focus a lot or spend a lot of time talking about education, but education is so important, not only for patients and caregivers, but also oncologists as well, and other members of the team. Oh, and by the way, we have a very strong nursing group, working group in our organization, and they have been fantastic. So they are developing a lot of pathways and guidelines as well.
Well, that's fantastic. I'm a big fan of nurses. Okay, let's see. Oh, that brought up that related question. So one of our participants mentioned trying unsuccessfully to request a switch to be your patient in particular, due to the desire to have a provider with both cardiology and oncology expertise. So how many other cardio-oncologists are there in New York State? And how would you recommend anyone might request to loop those exceptional providers into one's cancer survivorship team?
Very difficult question. First of all, I'm sorry to hear that. Again, you can share my email, and I will do what I can to get people in where they would like to be. I can tell you what we're doing here in Rochester is very unique. So I actually have my breast practice at Pluta, But I also have a day I spend working with the cardiologist, and I see patients in the cardio-oncology clinic with the cardiologist. And that kind of program is not being done anywhere that I'm aware of in the United States. So happy to sort of, help anyone. But in terms of survivorship, we also, my other hat I wear is the director of the survivorship program here at the Strong and Wilmot Cancer Institute. So we are just about to launch a new survivorship program and clinic. Part of that will be expanding access to survivorship, not just from what we typically think of it, but also including the cardio-oncology piece. So cardio-oncology is part of survivorship. And I would say stay tuned. We're working on that. In terms of the number of cardio-oncologists in New York State, I'm relatively new to the state, but I would say probably there's only a handful, probably anywhere between 6 to 7. And also we have to be very careful about who calls himself a cardio-oncologist. So anyone right now, because such a new subspecialty, there aren't a lot of government regulations around who can call themselves a cardio-oncologist. Within our organization called ICOS, we actually do have a criteria. So we have courses, we have an exam that people write, and we have a designation that you have to earn to become a fellow. And so this, again, this is non-government, but it's sort of our organization has done this to try and at least guarantee that individuals who call themselves a cardio-oncologist have a certain level, a certain skill set. I'm also open, if other people know of cardio-oncologists, or I'm open to hearing that, but in terms of our hope here at Wilmot and in Rochester is not just to be a Rochester program, by the way. So our hope and the reason why I came here to Rochester was to grow the program so that there will be access, not just here, but in all the surrounding, all upper state New York. So that's sort of my territory. I feel at least I can help grow the program. And again, ideally bring some of those services to individuals. And if it's not physically where you live, at least maybe through, a video visit.
That's wonderful. And I think people, I mean, I know after my own work in outpatient infusion, people travel from Pennsylvania for treatment here. There's Ohio. So there's people traveling a long way to come and see you and the other providers in your department and on your team. So we're really lucky to have you. Thank you so much for coming. I'm not done with questions, don't worry.
Yep.
Now we have some exercise related questions because
Yeah.
before you shared that study, I think this might be the same study somebody said. There was an article today in the New York Times entitled "Exercise Extends Life for People with Cancer Study Shows" about a study involving colon cancer survivors and the benefits from a structured exercise program. How should cancer survivors have an exercise program prescribed just as heart patients do now, in your opinion?
Yes, so that's a short answer, but let me sort of expand upon that. So yes, that was a study that I was discussing, that's exact study in New York Times, talking about the benefit of exercise. And I think the reason it's received so much interest is the first study to show a survival benefit from exercise, specifically in cancer patients. A few years ago, the American Heart Association wrote a position paper on the benefit of exercise and how to structure that in cancer patients. But again, and I'm a strong advocate of that. And I think that, while we're still sort of learning, and I think someone asked a question about how much exercise, we're still learning about exactly what that should be. I mean, we say 150 minutes a week, total of any type of exercise. There's two things we need to do. There's still ongoing work to define what's the best exercise prescription for an individual person. So we're still working on that. These individuals had guidance, and I think I don't remember exactly offhand the exact exercise prescription, but they had a lot of coaching. And secondly, with this article that's just been published, and now in the media, we need to go to the insurance companies and say, this is something you need to reimburse. right? So you can, if you have had cardiac rehab is paid for, it's part of your rehab. So I've always wondered, if we're giving you cancer treatment and you've become very deconditioned and there's data showing that, why can't we have cancer rehab? Why don't we have cancer rehab where you can go and see a nutritionist, you can have your exercise prescription, you can have, yoga if that's helping with your flexibility, if that's good for you. All these things should be part of cancer rehab. But we tend to say, oh, you finished your cancer, you should be cured, go off and live your life. But as we know, that's not always possible. And it's not always the best thing. I was speaking to an individual a few days ago who had Hodgkin's lymphoma and underwent extensive treatment. And they said, oh, your PET scan looks good. We're happy you're cured. And she said, that's great, but I've never felt this horrible in my entire life. Like, what do I do now? She was so deconditioned. She was so broken down from her treatment. And she said, I would have liked at that time for someone to sit down with me and say, we can help you. And these are some of the things we can help you to feel better, right? So she was happy her cancer was gone, but she felt horrible. So again, it's that idea of I'm a strong believer in rehab. And actually in my earlier training, my initial university days, my training was in exercise physiology and kinesiology. That was in my undergraduate training. So yes, you've asked the right person. The quick answer is yes. Now we have to advocate for coverage and we have to get these programs up and running. And we're so fortunate, at least at Pluta, here in Rochester, we do have access to exercise programs. And, wearing my hat again as survivorship director, I want to try and expand that so the access to all people in this region with cancer, right? Not just, those fortunate enough to have breast cancer and have access to Pluta, that this is something that we really need to provide broadly across the region.
Right. And you mentioned those social determinants of health too. So who has access changes dramatically with where people live and the sorts of care that they can access or can afford to access.
Right.
Luckily, we provide free services at the coalition, but that's not always accessible for people if they're out of state, or if they want to do things in person and are far away and don't have technology to access things on Zoom. And there's also the Livestrong programs through the Y that are free for cancer survivors. And those are all cancer survivors too. I've heard wonderful things about that, but even still, it would be really nice if insurance would cover a more holistic approach for people's health and well-being to help people feel whole.
I think it's so important because, we know that, I mean, if it's preventative medicine in a sense, right? Because we know if we can bring people, if we can get them out exercising, eating better diets. We didn't talk a lot about this, but mental health. Mental health is important too, not just the physical health. And trying to look at the whole person, that these are individuals that are going to contribute to society. They're going to stay out of the emergency departments. They're not going to be, visiting multiple healthcare providers. I mean, I was just, so happy today when I saw an individual and she's living with metastatic breast cancer. But you know what she said to me? She was a really rough go with her treatment, but she said, you know what? I'm back to work. I've been working for 6 weeks now, full time. I feel great. And that is what to me is success, right? I mean, the scan, okay, is the disease like this much or that much, but when someone says that, that to me is success.
Yeah, that's that's wonderful. That's probably one of those things that helps you to keep going, I would guess.
Absolutely.
The best part of your day.
There can be rough times, as we all know,
Yeah.
and as patients and survivors go through rough times, so do providers. Um,
Hmm.
and I think we do really feel it when people aren't doing well or when they're having a hard time with their treatment. But it is so nice to see have those positive experiences and to be able to share with people those positive experiences. And when you say to someone that, I think we can make a difference in when it does actually happen, that is just so rewarding.
Yeah. And I think even this webinar already, it seems like giving people hope that they don't have to struggle through this stuff alone and suffer quietly and silently without the ability to access help. that help exists, and feeling empowered to go find it and to go talk to somebody about what you're dealing with. We're all here. I feel like we could just keep going because this has been so wonderful. But I want to make sure I get to the rest of the questions that have been shared. One of those questions about sort of the long-term prognosis following treatment was, what causes the late onset of heart failure, potentially occurring years after finishing chemo? Why such a long duration?
Yeah, that is a very, very good question. So, when we think about radiation, again, it can cause scarring of
Mm.
the heart coronary arteries. It can cause scarring of the valves. And we know that scar tissue occurs over years. And then as those arteries and valves get stiffer and stiffer, they can stop functioning. And so that can cause, what we call coronary artery disease, valvular heart disease. It can also sometimes cause the pericardium, which is that sac around the heart, to become stiffer and then harder for the heart to squeeze. So those are things that happen over many years from a radiation perspective. Anthracyclines can cause damage to the heart. It's actually directly toxic to the cardiac myocytes. And while that may not be evident, it can take time. The heart can compensate for a while, but over time, what may be happen is the ability to compensate may decrease and the heart just gets bigger and less able to pump blood. And of course, as we age, if you put on top of that maybe some hypertension, because as we get older, we are more prone to that, maybe some diabetes, these contribute as well. So that is why you'll hear and of course, then if you give drugs like an anthracycline and then you had maybe a HER2 targeted drug, the combination, maybe the two work in synergy. In fact, we understand now that we don't usually ever give anthracyclines with a HER2 target therapy together because it's such a high risk. So that's why some of these things take time and they aren't immediately toxic to the heart, but they cause enough damage and the heart can manage and compensate, but eventually kind of starts to, fade out in combination with aging and all the other cardiovascular risk factors that we tend to put on top of that. But you do hear that. In fact, you know, interesting, I didn't mention this, but we also see people who have cardiovascular disease and then develop cancer. And so there is sort of this bidirectional, what they call bidirectional relationship now, where we think that some of the common risk factors that are discussed tonight not only can lead to premature cardiovascular disease, but those people with cardiovascular disease that have those risk factors can also develop cancer. So we're learning more and more about the sort of the interaction, how, again, this comes back to the whole person, right? That all of these things impact the whole person, not just one aspect of them.
It's all related, it's all connected, so it behooves them to support an entire person. Seems straightforward. Um, Another question was, what should one be aware of with long-term use of Keytruda or other immunotherapies?
Ah, that's a good question. So Keytruda, otherwise known as pembrolizumab, is an immune checkpoint inhibitor. It's immunotherapy. It's approved for the use in multiple types of cancer, in particular triple negative breast cancer. Either those patients living with metastatic disease who have what's called a PD-L1 mutation, or more commonly, we see it in high risk early stage triple negative breast cancer. That's those who have lymph node involvement or have a large tumor. So we use it in combination with chemotherapy. It's this regimen called Keynote 522. So, and it's made significant improvements in outcomes for women with triple negative across many cancers, but in particular breast cancer, triple negative breast cancer. But, and there's always a but. I mean, we think with any new treatment that comes into the clinic and we see these great responses, I think there's always a but. And the but with Keytruda is that it can cause a lot of immune-related side effects. So what are those? thyroid function. So we know it can cause hypo or hyperthyroidism, okay? More commonly hypo. And that's why when people are on this treatment, they often will measure their thyroid function. It can affect the adrenal glands or that produce a hormone called cortisol. And if that, is knocked down, then people become very, very tired. It can affect just about any system in the body. It can cause, of course, skin toxicity, rash. It can affect the GI system. The concerning about that in terms of long-term side effects is if you develop one of these so-called, what I call endocrinopathies, like if it affects your cortisol, if it affects your sugars, if it affects your thyroid function, quite often those are permanent. So, people that we see that develop, for instance, a low thyroid function or hypothyroidism, they end up being on lifelong thyroid therapy. So it's important to understand that and respect this class of drugs. And it's for this reason that when I see people who have perhaps are older or have a very what I call performance status, poor performance status, I really do have to have a one-on-one talk with them because I do get concerned about the potential toxicity from this treatment versus the benefit and the expected years of life left that they may have. And I have personally seen people admitted to hospital very ill with these drugs, not to scare people from them because they're great drugs, but you do have to be very careful. And unfortunately, some of these toxicities are lifelong.
Oof, that's
Oh, and by the way, that's the drug I mentioned can cause heart problems as well. I mean, it causes things like the myocarditis, inflammation of the heart, pericarditis, or, as well. So again, that's rare, by the way, only 1 to 2%.
okay.
But if you do develop it, the fatality rate is about 30 to 50%. So again, I think I've learned to really respect that class of drugs and be very careful when you're prescribing them. And it's always reevaluating with every cycle what's happening. If you get through your treatment and you've completed your treatment and you have not had any of these side effects with that drug in particular, you're probably okay. They tend to occur like during the treatment, right?
Not a long time afterwards.
Correct.
Okay, so it's not a delayed thing, which
No,
is
no,
also
yeah, not that, of course, these drugs have only been in the clinic for a few years, but most of that toxicity is immediate, not delayed.
okay. We have, let's see, 2, 3, 4 questions left, which I think we can do in 8 minutes. Someone asked, is the coronary calcium score accurate after receiving prone radiation for breast cancer, or would quote unquote bad cholesterol level be a more accurate measurement?
Oh, okay. That's a complicated, but anyway, so coronary artery calcium scores can help predict, your level of atherosclerosis in your coronary arteries and can be used to determine your risk down the road of that. The problem with if you've had radiation recently, you probably won't see the impact of that on your coronary arteries for years down the road. Could be 10 or 15 years. So coronary artery, if you were to have that score done today, it's reflective of what you've been exposed to or experienced in your life, probably in the past 10 years or so. So I would say, if you have one done now, that could be a baseline. And if you've had radiation, you might think of 5 to 10 years down the road, you can repeat it, and then you can see if it's changed. But it is something the cardiologists use to try and predict risk of coronary artery disease.
Okay, that kind of goes into the next question, which was about, exposures for somebody who received radiation and also CMF and Red Devil. It seems like over 16 years ago.
Right.
How long are you still concerned about cardiovascular impacts? And how long, the big question I think for most folks on this presentation is how long should people continue to monitor? And is it sort of forever? or is there an end time?
You know, I think that's a good question. Unfortunately, I don't have a lot of data to share with you, but I would say it's a lifelong risk. So think of this as that you have had an exposure at some point, whether it be radiation or anthracyclines, and that may, at some point down the road, you may develop some symptoms that are consequence or due in part to the anthracyclines, but that in combination with the fact that you've now developed hypertension or you've now developed diabetes. So as we age, we're all at risk of these things. So I think your cardiovascular health is a lifelong issue to address. And when you are addressing that, whether that be with an ECG periodically, monitoring your blood pressure, taking your medications if you have hypertension, the cancer treatment is one factor to consider amongst all of those factors. And so cardiovascular health is a lifelong concern. And, you know, what type of investigations and monitoring you should have down the line years after is really reflective in that article I showed you based on that looked at your baseline risk, right? So those people who started who were on cancer therapy already at high risk for various reasons, those are the ones they said, well, maybe you should have an echocardiogram or heart ultrasound every 5 years. You know, these are some of the things that they're suggesting because of their high risk at the beginning. So that will determine some of your surveillance. Unfortunately, unlike the adult cancer survivors of childhood malignancies, we're still trying to define exactly what those tests should be. And that's where I think AI can hopefully help us. That if we put in, you know, your age, you know, your pre-existing things and what you're exposed to, it can come out hopefully looking at big data and say, this is your prescription, and this is how you as an individual need to be followed. Because right now it's pretty crude and it's sort of us sort of thinking as experts, like this is what we should do.
Yeah, and it's very subjective and maybe, um, you've been a huge proponent of a multidisciplinary approach, but not everybody has that sort of perspective. Um, let's see, I wonder if we can get through the last two. Um, how can we as individuals advocate for greater investment in cardio-oncology, both by healthcare systems and greater support by insurance companies?
Yeah, I think that's important that we continue to educate people, institutions, um, cooperative groups such as ASCO, and continue to really focus on doing more research in this area. So, you know, we here at the University of Rochester are just received a grant, a small grant from the Department of Medicine looking at how often we do echocardiograms in women with HER2-positive breast cancer. We're also adding into that grant doing what's called an AI ECG. So artificial intelligence is now actually looking at ECGs, those heart tracings that may actually be able to determine what your ejection fraction is. So I think if we can continue to do more research to show the benefit of what we're doing, at the same time, of course, we don't want to wait forever, advocating at every level, including, you know, right here in Rochester. I'm advocating with the Strong Memorial Hospital, the Wilmot Cancer Institute. You know, we have the Warrior Weekend coming up where we raise funds, and I'll advocate for some funds to sort of help us that. But it's I think a multi-pronged approach, looking at education, advocacy, and research. And of course, as we're doing that, really, you know, focusing on clinical care. At the end of the day, it comes down to clinical care. But to improve upon that, we have to have, you know, be really work on all those other elements. So I'm happy if anyone wants to advocate for work, you know, with us. We also, you know, with our International Cardio-Oncology Society, we also have a survivorship working group. We have advocates joining us on that as well. So that has really been part of what I've been trying to do probably for the last 15 years.
Yeah, and unfortunately, as research budgets are getting cut and squeezed, it seems like there's no shortage of room for advocacy and improvement in that regard. So I hope that, yeah, our collective
Well,
power and voices can help push push in the right direction.
I think so. And I think that, it's forced us to look into new directions and working with partners. So one of the grants that we were just, and will be a site, is we just received a large grant from the CIHR. So you will probably know that that's the Canadian Institute of Health Research. So we are doing a cardio-oncology study working with the University of Toronto. So, yeah. So, I mean,
Hooray.
yeah, it's exciting.
Because we can't collaborate across the border.
Yeah.
So,
Yeah, I know. But so far, things are going well in that regard. So, I mean, I think that it's forced us to look at different ways to look at how we can do things. I don't think we can just stop doing these. It's important research that needs to be done. But I can also tell you that we're fortunate here. We are working with an AI company out of California, and they are going to be coming to the University of Rochester to do a study with us, looking at, yes, looking at a wearable to look at heart function. And so, we are always looking at different partners and ways to try and achieve some of the answers. So I am really excited about the future in this area, and I think happy to always open to suggestions, by the way, from, people on this webinar for ideas around advocacy. In at the end of October of this year, I'll be traveling to Cape Town, South Africa, because not only are we advocating for, better care here in upper state New York and Rochester, but we're also looking at how can we bring some of this care to low and middle income countries, and that will also help serve us here in the US and North America as to how do we bring care to people who, don't have the resources to come see us.
absolutely. That's wonderful. Thank you so much, Dr. Dent,
Oh,
sharing your time with us and your expertise. Thanks to everybody who could. Somebody is requesting your email,
I'm
which,
putting it in the chat right now.
okay, great. Thank you so much for that. Thanks to everybody for sharing a couple hours on a beautiful summer evening with us. Our next webinar is about integrating complementary therapies. So all this talk about holistic personhood and holistic health. If you're interested to learn more about such therapies like acupuncture, Reiki, and Qigong, please join us on August 27th for our next evening webinar. And I hope to collaborate with you in the future, Dr. Dent. Thanks
And
again.
I just wanted to mention, by the way, October 10th at the Memorial Art Gallery, we're having a survivorship night, right? Open to any survivors. If you're interested, you can send me an email, and it's going to be really great. And we'll also, at that meeting, we will have, I think we actually, maybe your group may be there as well, but we'll have Live Strong, 13 to 30, and we are trying to work much more closely with different partners in the community. So not only can we offer what resources to survivors that, are available at U of R, but we can let survivors know what's available in the community.
Yeah, because we are resource rich, but not everybody knows what the resources are, so we can elevate each other. That sounds
Exactly.
wonderful.
Yeah.
Love that. All right. Take care, everyone. Have a great evening.
Thank you.